So we continue with the second part of our talk, preconception and antenatal care. We have already discussed preconception and we started on the antenatal care, how to diagnose pregnancy and what sort of problems that could occur preconceptionally and accordingly you manage them. So we carry on the second part of our talk, the organization of the antenatal care. Usually, if we are talking about UK, for example, it is the general practitioner who does the antenatal care. Or in our situation, it could be a medical officer, not necessarily a consultant. But traditionally, it could be done by general practitioners, GPs or medical officers, community midwives, hospital midwives, and consultant obstetricians. All these could traditionally do the antenatal care. Caregivers, women are better informed and prepared for with these general practitioners, midwives, or consultant. The women are better informed and prepared for labor, attend more antenatal classes, have fewer antenatal admissions. That's if the antenatal care is being conducted properly. If possible, the one who performs the antenatal care should be the same person every time the lady comes into hospital or into the health center, preferring to be the same person who are seeing the ladies. So what do we do in the antenatal care? First, documentation. You have to document it. Everything should be documented. Documentation acts as what? Source of information and a mechanism of communication between health professionals. It's already in her notes. So whoever medical professional or caregiver comes to look at the patient, he will find the documentation in her notes, what has been done. The basic information are already there. Also, it's a legal document. Just tell that I have done so, and that's the legal document for you. There is good evidence that women to be allowed to carry their notes. We know they are in places where everything is being put in the system, paperless hospitals, if there are there any, but where there are notes, preferably to be taken and carried by the woman herself. That's because she feels that she is in control of herself, knowing the information, knowing who saw her, knowing whatever she wants to do. And also, the information will be available to other clinicians in case of emergency. So document and give the document to the lady to take with her. When she comes next time for you, you add information on that. But if she went to see another caregiver, then the information are already in her notes, which she is carrying with her. So that is the documents. The antenatal visits. The first antenatal visit or booking visit needs to be before the 12th week, if possible, early on in the first trimester. This is the first antenatal visit. Get information about the pregnancy, such as diet, smoking, folic acid, etc. That is in the booking visits. Identify those who are at high-risk pregnancies. And then you will plan how to manage those of high-risk pregnancies and those low-risk pregnancies, how to be managed. We do screening tests in the first visit, and then the next visit should be at about week 16. That is to discuss the results and give information about antenatal classes. Plan for the future visit, so 12 and 16 weeks. At 20 weeks, we do anomaly scan. So You know that this is the duration of the pregnancy. We have to calculate it. Normally, pregnancy is about 40 weeks from the first day of the last normal menstrual period. Then we do legal rule, and it tells us that the estimated date of delivery to be calculated by adding 7 days to the date of the first day of the last menstrual period and count back 3 months or subtract 3 months. An example we give, if the last menstrual period on the 10th June, the expected date of delivery will be on 17th March. Just an example. Nowadays, we use this calendar, help us greatly to calculate how many weeks she is pregnant now. And that is also defined or designed along this information. You know, this trimesters of pregnancy has been customary to divide pregnancy into 3 equal epochs of approximately 3 calendar months, approximately. First trimester till week 14. Then 14 and 28 weeks, it is the second trimester. 29th week and 42nd week is the third trimester. So you will know this. Thus, there are 3 periods of 14 weeks, starting first trimester, second and third trimester. How to plan the antenatal visits? Traditionally, every 4 weeks intervals until 28 weeks, and then every 2 weeks until 36 weeks, and then weekly thereafter till delivery. That is a traditional way of doing it. But women with complicated pregnancy often require return visit at 1 to 2 weeks intervals. That's everything is low risk, we use the traditional one. If she's high risk, then we may need to see her earlier or more frequently. The WHO put a new model for the visits of the antenatal care. They say once in the first trimester and screen for certain risk, then at 16 weeks. First trimester, as we have mentioned earlier, you do certain tests, you inform, you divide them already, those high-risk pregnancies, low-risk pregnancies, then you see them at 16 weeks. So first trimester, if possible, before 12 weeks, then at 16 weeks, then those without anticipated complications, low-risk pregnancies, which compose about 80% of all pregnancies. These to be seen at 26, 32, and 38 weeks intervals. That's to say, in the traditional one up here, we see the lady 8 times during pregnancy or 8 visits. Sometimes it be more than 8 if she's a high risk, while in the new WHO model, it's about 5 visits at booking, 16 weeks, 26, 32, and 38 weeks. These are definitions you need to know. I'm sure you already know that. Null gravida, women who currently is not pregnant, nor has she ever been pregnant. Null gravida. Gravida means a woman who is currently pregnant or has been pregnant in the past, irrespective of the pregnancy outcome, whether that ended in a miscarriage or hydatid formal or whatever it is, but she has been pregnant before. These we divide them into 2 groups or more. Prime gravida, having her first pregnancy, multi-gravida having successive pregnancies. So gravida, so you can say gravida 6, para 5 plus 0. That means she, in her 6th pregnancy, she had 5 deliveries that went beyond 20 weeks priorly. Nullipara, a woman who has never completed a pregnancy beyond 20 weeks of gestation. She may not have been pregnant or may have had spontaneous or elective abortion, or an ectopic pregnancy. So this is on the LIPRA. Primipra, a woman who has been delivered only once, of a fetus or fetuses born alive or dead with an estimated length of gestation of 20 weeks or more. Primipra. She is not pregnant now, but she had one before. Beyond that, went beyond 20 weeks, irrespective of how it ends. Multipra, a woman who has completed 2 or more pregnancies to 20 weeks gestation or more. The important for us here is the grand multipra, a woman who has completed 5 pregnancies or more over 20 weeks. Let's say 5 pregnancies that went beyond 20 weeks. 5 pregnancies or more. The serious or the complications we tend to worry about are in primip gravity and grand multiplia, who have 5 pregnancies or more. These are subjected to certain complications we have to do. So at the booking, what sort of test should we do? We do complete blood count, blood group or rhesus factor, check for diabetes in blood or urine, sickle cell and thalassemia. In our country, we got certain places which are known that the people have sickle cell disease there. Okay. We do infection screening for rubella, HIV, syphilis, hepatitis B and C. So these are the tests which we need to do at booking time. At each visit after that, we go for the fetus and the mother. What do we do for the fetus at each subsequent visit after the first visit? Look for the fetal heart rate. It is there, audible. You can look for it by the PNART or the Sonicare, Doppler, ultrasound machine. It just tell you the presence and the fetal heart rate. You look for the fetal growth. You do that clinically by abdominal examination and assessment and ultrasound. You measure the amniotic fluid by ultrasound, and clinically you tell whether this amniotic fluid is larger than normal, less than normal, or just the average. And you look for the fetal activity. So these are parameters which you have to look for on the fetus: fetal heart rate, fetal growth, amniotic fluid volume, and fetal activity. What do you do in the mother? You look for the symptoms on each antenatal visit. Has she had any symptoms that she will tell you in the history? Could be like headache, altered vision, abdominal pain, nausea and vomiting, bleeding, vaginal fluid leakage, dysuria. All you check about those. Check also maternal blood pressure and her weight. Do urine tests to check for albumin, for diabetes, glucose and ketone bodies, for infection. Do uterine examination. You measure the size from the symphysis pubis to the fundus. We used to say in fingers, let's say 3 fingers above the symphysis pubis or 3 fingers above the umbilicus. Nowadays, we don't use that. We use a tape measure, and you measure it from the symphysis pubis to the highest point in the fundus. And you tell that it's in inches or centimeters, whichever way you are doing it. Then in each visit, you look for antenatal D prophylaxis. Rhesus negative women to have prophylaxis of anti-D at 28 weeks and a second dose at 34 weeks. In the past, we wait till delivery and then we check the cord blood for blood group, and we decide to give anti-D or not. Nowadays, rhesus negative pregnant ladies should be given a prophylactic dose during pregnancy at 28 weeks and 34 weeks. At 36 weeks visit, You check for the position and presentation of the fetus, cephalic, breech, whatever it is, longitudinal lie, oblique lie, you check for that. And you document that on the patient notes. Late in pregnancy, they can do a vaginal examination to assess the cervix. So blood pressure, what happens to it during pregnancy? Falls by a small amount in the first trimester. Normal pre-pregnancy blood pressure, in the first trimester, it comes down a bit. Then it increases to pre-pregnancy levels by the end of the second trimester. First trimester blood pressure assessment allows the detection of a previously unrecognized chronic hypertension. That's to say, it's very important to check the blood pressure. She may not know that she had hypertension, but on your checkup, you'll find that she is hypertensive. And she doesn't know that, and accordingly, you plan the management. This enables early initiation of treatment. So check the blood pressure, knowing that there is a fall early in the first trimester, and then it comes back to the normal pre-pregnancy level all through pregnancies. If it gets higher, then this is a sign you should look for as abnormal antenatal problem. Ultrasound. First trimester visit, we do ultrasound, and it tells us accurate dating of the pregnancy, tell us early identification of multifetal pregnancies. We use it for screening of trisomy. Here, this is the pregnancy. It tells us this is the uterus, and this is the intrauterine pregnancy, and it is single. If it is twins or more, it will have two gestational sacs, which you see them there. So it confirms the pregnancy, shows you the fetus. You can check the fetal heart on it, and also you identify multifetal pregnancies. Screen for trisomy, we'll see in a minute how to do it. Then examination of the fetus for gross anomalies such as anencephaly and cystic hygromas. That is in the first visit, and accordingly, in each subsequent visit, we may need to do ultrasound. Not in each of them, but sometimes in each of them, in others, in certain places, certain situations where there is an abnormality. As I have mentioned, dating of the pregnancy by the ultrasound, first trimester ultrasound. By ultrasound, how is it read? Best performed between 11 plus 3 days and 13 plus 6 days, just before 14 weeks. If you do it at this time, then you take the crown rump length measurement as the gestational or as the of dating of the pregnancy. Crown rump length at 11 plus 3 days is about 45 millimeters, at about 13 plus 6 days, about 84 millimeters. That usually during this period, we use the crown rump length. Seeing the patient later on at between 14 and 20 weeks, the best will be the head circumference used to detect and calculate the expected date of delivery and the gestational age of the fetus. So initially crown rump length, later on head circumference to do that. After 20 weeks, the scan can become less accurate for dating, for genetic and environmental factors. Because of those, it becomes inaccurate for dating of the pregnancy. Before 20 weeks, we do it, either using crown rump length or using head circumference. So screening for trisomy 21, as we have mentioned earlier, in the first trimester. What do? We do ultrasound. We look for the knuckle translucency early on in the first trimester, the first ultrasound. The median and 95th centile is about 1.2 millimeters and 2.1 millimeters. The median at the crown rump length of 45 millimeters. That's if you find the crown rump length 45 millimeters, you expect that the median 1.2, the 95th centile 2.1 millimeter for the knuckle translucency. And it could be this level at 84. And as we have mentioned, crown rump length at 13 plus 6 days is about 84. At 11 plus 3 days is about 45. So these are the figures you take with each crown rump length for the knuckle translucency. More than that, this is trisomy. Probably there is trisomy 21. And accordingly, you do what you do for the management. This is by ultrasound, screening for trisomy 21. We can do other parameters for trisomy 21 diagnosis. These are measurement of maternal free beta HCG and measurement of pregnancy associated plasma protein A. Measurement of these will help us also to suspect and eventually diagnose trisomy 21. Measurement of maternal free beta HCG quantitatively and measurement of pregnancy associated plasma protein A. How we then read them in trisomy 21, free beta HCG is higher and the concentration of PAP A is lower. So either by ultrasound or by measurement of maternal hormones and proteins. Accordingly, you will diagnose trisomy 21. And with that, of course, the maternal age is from the start will be suspicious whether she had any or not. That's in the first trimester. Screening for trisomy 21 in the second trimester, between 14 and 20 weeks gestation. This consists exclusively of risk prediction using maternal biomarkers. Here, the ultrasound may not help very well. We use maternal biomarkers to tell us whether there is trisomy 21 or suspicion of trisomy 21 or not. And this is part of the antenatal care you have to give to the lady, especially at an old age. These maternal biomarkers, we call them the quadruple test. That's say 4 things. And these they are maternal alpha fetoproteins, beta HCG, unconjugated osteols, and inhibin A. You check those on the mother, and accordingly, or according to the results, you will be able to say whether there is suspicion for trisomy 21 or otherwise. Because this quadruple test had an 80% rate of detection with a 5% false positive rate. So it can diagnose up to 80% of cases, quite reliable. And we do it by 14 to 20 weeks. And accordingly, you manage the pregnancy if you confirm that it is trisomy 21 pregnancy. Screening for fetal well-being. At each visit, what you do to the fetus. You do auscultation for fetal heart. Obviously, just this is to tell you auscultation, but we don't need the this stethoscope. We use either the pinner, the one you put on your ears, or more frequently the sonic aid, Doppler ultrasound. You hear the fetal heart rate, and you can measure the rate. Good thing about it that the mother will hear the sound of the fetal heart beats with you. So On each visit, you auscultate for the fetal heart, do abdominal examination, measurement of the symphysis pubis fundal height. As I have said, you use the tape meter to measure it. Estimation of the fetal size. Is it within normal? Is it more? Is it less? Then you do the maternal weight, and you ask the lady about the fetal movement, which she is appreciating during her life normally. Does the fetus move? If it moves, how frequently? The mother could tell you. That is just being a subjective information. You confirm it with auscultation and looking for the fetal movement during the procedure of ultrasound or during the clinical examination. So at each visit, this is what you should do. You give advice also at each visit about certain things, advise, reassure the woman or the couple, and educate her about certain problems. Common symptoms you reassure her about: nausea, heartburn, constipation, shortness of breath, dizziness, swelling, backache, abdominal discomfort, and headache. These are minor ailments. They are always there. Not necessarily always, but in most situations, they are there. So reassure the patient or the pregnant lady that these are normal for the pregnancy, common for it, and then you give her treatment for whatever you think that needs treatment. So this is education, reassurance, and then management. Also, you tell her about smoking because it is associated with fetal growth restriction, associated with preterm labor, placental abruption, and intrauterine fetal death. So if a lady is a smoker prior to pregnancy, you advise her against smoking. She should stop it, and that should happen from the first antenatal visit. You check on it later on. Alcohol and illegal substances could be dealt with by special centers. If she's an alcoholic or an addict, she's using marijuana, narcotics, morphine, whatever it is, you refer her to the specialized centers where they could manage her accordingly, because these are also deleterious on the fetus. Parent-craft education as formal group discussion of issues relating to pregnancy, labor and delivery, and care of the newborn. You have to educate them. Parent-craft education entails that the mother and the father should be there to know it. We don't do it in our situation, but it should be done. Even if for ladies only, the pregnant ladies only, you had to give them information and education about the pregnancy itself, what they may feel, what happens, how pregnancy normally progresses, about labor, what she expects to labor, about the delivery, mode of delivery, and also how to care for the newborn. All these classes should be in group discussion classes prior to delivery, during pregnancy, giving her education about the pregnancy, the labor, the delivery, and the care of the newborn. Dietary advice. Vegetarian diets are usually deficient of protein. You may see vegetarians, but this can be corrected by increasing egg or cheese consumption. This is vegetarians. Anorexia and bulimia increase the maternal risk of nutritional deficiencies, electrolyte disturbances, cardiac arrhythmias, and gastrointestinal pathology. So if you had anorexia or bulimia, you have to manage that. Pregnancy-related complications include greater risk of low birth weight, smaller head circumference, anencephaly, and small for gestational age. That is, if a lady is having anorexia or bulimia and if the diet is not properly balanced. The dietary advice you give to the lady, because maternal weight has an impact on pregnancy and its outcome. Low BMI is associated with intrauterine growth restriction. High BMI or obesity associated with greater risks of hypertension and preeclampsia, neural tube defects, gestational diabetes, risk of labor abnormalities, shoulder dystocia, cesarean delivery and operative complication, and anesthetic complication and morbidity. So all these are associated with obesity or high BMI. So your job as an obstetrician or a caregiver is to make that the BMI for that particular lady is within the normal reference range, not too low, not high. Also, dietary advice, you advise them about what we call pica. Pica is the craving or consuming of certain things, ice, laundry starch, clay, dirt, or other non-food items. That's common. You find it in our situation or in our country. Pregnant women start to eat clay. That's pica. She should be discouraged to do that. Those who are doing other form of pica also should be discouraged about doing it, to eat a diet, normal diet. The RCOG, the Royal College of Obstetricians and Gynecologists, provides the following dietary advice for optimal weight control in pregnancy. Do not eat for two. She is pregnant. She thinks that she had another person with her. Somebody will advise her that you are two, you have to eat more to equal the normal two people can eat. No, she shouldn't do that. Also, she avoids snacks in between. Eat fiber-rich foods such as beans, lentils, whole grain breads, seeds, and fruits. Eat starchy foods such as potato, rice, and bread. Restrict intake of fried foods, drink, and confectionery, fruits and vegetables to be eaten, and avoid dieting during pregnancy, but control the weight gain. If she is obese, to avoid dieting, but just try to keep the weight gain as normal as possible. So this is the dietary advice of the RCOG, or the guidelines you do. You give advice during pregnancy for exercise. Pregnant women usually can continue to exercise throughout gestation. If she is if she's a runner, gymnastics, or others, any sort of exercise or sports, she can continue on that. But as pregnancy progresses, balance problems and joint relaxation may predispose to orthopedic injury. So exercise that could affect the balance should be discouraged. Women should be advised not to exercise to exhaustion, and she should augment heat dissipation and fluid replacement. She should give for that. And avoid supine positions normally or in exercise, or if she is going to the gym, she may need to do certain procedures in the gyms or activities in the gym that involves supine position. That should not be done to her. Avoid activities requiring good balance, and extreme weather conditions should be avoided. So she can have exercise, but these are the precautions you tell her for it. Immunization. during pregnancy. You have to advise ladies. Following immunization have not been associated with adverse fetal outcomes and are not contraindicated preconceptionally and during pregnancy. Preconception, you can have them, or during pregnancy. These are, which are not contraindicated, vaccines that contain toxoids. Example, tetanus toxoid. We usually give it during pregnancy. Vaccines that consist of killed bacteria or viruses, killed bacteria or killed viruses. These are influenza vaccines, pneumococcus, hepatitis B, meningococcus, and rabies. These also could be given during pregnancy. But live viruses vaccine should not be given during pregnancy. These include varicella zoster, measles, mumps, rubella, poliomyelitis, chickenpox, and yellow fever. These are not recommended during pregnancy because they contain live virus vaccines. So this is the advice about vaccination for your lady. Anti-D, as I have mentioned earlier, a lady who's rhesus negative, married to a rhesus positive, or carrying a rhesus positive baby in the first pregnancy, nothing would happen, but she will be sensitized because fetal red cells go from the fetus to the mother. The mother will develop antibodies for them, and then she will be sensitized for the subsequent pregnancies. The first pregnancy, she may not be affected. So we give usually anti-D administration at 28 weeks gestation for rhesus negative women. As I mentioned early on, we used in the past to give it at delivery after checking the blood group of the baby. But nowadays, rhesus negative women who is not being sensitized, she should have anti-D at 28 weeks. Anti-D is administered in instances of potential sensitizing events. 28 weeks, as we have said, and then at potential sensitizing events. Early on 28 with 32 or 34 weeks should be given. Sensitizing events happening during pregnancy that may lead to release of blood from the fetus into the maternal circulation. These events post-chorionic villus sampling, amniocentesis, trauma to the maternal abdomen, ectopic pregnancy, molar pregnancy, therapeutic termination of pregnancy. In cases of repeated heavy uterine bleeding associated with abdominal pain, the anti-D should be administered as soon as possible, always within 72 hours of the event. These 5 events, we add to them external cephalic version. It is being done for a breech. All these are potentially sensitizing events, and accordingly, we have to give the lady who is rhesus negative, we have to give her anti-D prophylactically. We have to advise antenatally about breastfeeding. We should encourage the breastfeeding because it protects against diarrhea and common childhood illnesses such as pneumonia, may have longer-term health benefits for the mother and child, such as reducing the risk of obesity later in life. It has been shown to be associated, breastfeeding as associated with a higher IQ, intelligence quotient in children. It is a confounding factor. The WHO recommends initiation of breastfeeding within an hour of birth. Immediately after she delivers, you give her the baby, to put to her chest and give the baby the breast. Even we know that there is no milk at that time, but she has to start from that time. And it should be exclusive for the first 6 months and continued breastfeeding beyond 6 months and at least up to 2 years. You continue on breastfeeding. That is the WHO advice, which is sound to be taken by the mother to be. We just summarize now the coming 2 slides, just summary of all what you should look for on preconceptional counseling. Quite a big list. Summarizing it. Environmental exposure. Look for methyl mercury and lead. Ask about abnormal weight or advice about it. Cardiovascular disease, chronic hypertension, diabetes, thyroid, neurological disorders, renal diseases, asthma, infection, influenza, rubella, tetanus, varicella, dermatological disorders, cancer, connective tissue diseases, rheumatoid arthritis, and SLE. So all these just subheadings, you have to be aware that you would like to have them considered in your mind while you are doing the preconception counseling. To add to that, sexually transmitted diseases, is the list of them: gonorrhea, syphilis, chlamydial infection, HIV, human papillomavirus, HSV, hepatobiliary diseases, hepatitis B and C, hematological disorders, iron deficiency, anemia, sickle cell and thalassemia, hepatobiliary diseases, as we have just mentioned them, thrombophilia, psychiatric disorders, inflammatory bowel disease. Just summarizing all what we have to look for in preconceptional counseling. And this should be the last of our talk. And we hope at the end, we end up with a healthy baby looking like this one, and a healthy and good mother as a result of our preconception counseling and of antenatal care. Thank you very much, and we'll stop here.